First of all, again, I want to thank the Huntington Disease Society and then some of the sponsors for the HDSA and many of the programs that they have. Okay. Um, so for the next sort of 45 minutes or so, I'm going to just talk about some of the updates and treatments and clinical trials for Huntington's disease. I'm going to be shamelessly kind of plug our clinic location for some of you may be well familiar with our clinic, some of you may not. The University of UF Health Norman Fixel Institute for Neurological Diseases opened in 2019. We actually outgrew our old space. We are now located on Williston Road off of one of the main exits to Gainesville, Florida. We're off campus, which is ideal in some ways. One of the big reasons is parking is right next to our center. It's totally free, and you literally can park right at the front door. It makes ease of access fantastic. So we really have a one-stop shop for patients that come to our center. You can see the entrance here. You can drive up, go in. There's a nice, bright waiting room. To the right is actually our rehab area, and it's quite large. It's really fantastic. There's even an outdoor space as well. And to the left is actually the clinic and some of our research areas. But it really is one-stop shop. And for those of you who may not have heard some of the news, recently we also opened up the Dorothy Mangurian Research Center that's basically across the parking lot. That is a new research center with several research rooms. We have two on-site MRIs. We even have a PET scanner and a MEG scanner for those afflicted by different disorders. So we're really kind of embarrassment riches for folks. So we want to encourage patients. Access to our center is really easy. If you have any questions today, please reach out to us. My email's online and easily accessible. There is a web page for the Fixel Institute and for our HDSA Center of Excellence as well. And there are more information there that you can get online for the center. We really want to be a resource for all Huntington's patients and family members and for the community here. We serve most of North Florida or North Central Florida, but our reach actually goes way down south. There are several other centers of excellence in Florida, Tampa and University of Miami, and even in Orlando. So we're really the only center that's north of that, and our catch goes all the way up to Jacksonville and all the way to the west into the Panhandle and even further up into Georgia and Alabama. So for those who, if you're close to us, we want to we want to help you. We offer in-clinic visits as well as even doing telemedicine for people who drive a long ways and cannot make that. So please ask. Again, the website is easy to access, and there's a way to request appointments for our center. So I'm going to stop plugging our center and start telling you a bit more about some of the updates in Huntington's disease, which really excited to do. I've been doing this for several years now. And, seeing Huntington's patients and their families is actually one of the favorite things I do all week long. So I really enjoy seeing patients and helping families. And I think our entire team really does an excellent job. And those who do come here hopefully feel the love and feel that we really want to help you. So let me talk a little bit about Huntington's and give you some updates to begin with. Just as a basic overview, some of you probably don't need to see this, but I don't know if you recognize this guy on the right. Willie Guthrie, who had Huntington's disease. I'm going to talk today about some of the history, some of the epidemiology of Huntington's. We're going to toss briefly about features and the diagnosis, but really the main things I'm going to talk about there, sort of the new treatments or how I, as a physician, approach treating the symptoms of Huntington's disease. And I'm going to focus on the triad of symptoms. Number one, I'm going to focus on the motor symptoms. And then second, I'm going to, as I mentioned, talk about some of the neuropsychiatric features. So that means both the memory thinking issues, cognitive, we call that, as well as some of the psychiatric features. And honestly, some of those features are really sometimes more of a problem than actually the motor symptoms. And they can often predate. And I'm going to talk more about that. And then lastly, not to hold you to the end, but I want to talk about some of the research trials and clinical trials that are coming up today. Okay. So, um, someone asked me the other day, kind of, when did we learn about Huntington's disease? Well, it's been around for ages. Okay, so I don't really the um, discovery of this diagnosis, or at least the disease, wasn't until 1872, and it was discovered, or at least first described, by George Huntington, and he wrote a paper back in 1872. I don't think there are any other earlier descriptions, certainly not the name of the disease. So not surprisingly, it took nearly 100 years for us to figure out what the cause of the disease. Early on, of course, it was recognized that it ran in families. We just didn't know what the cause was. Um, Nancy Wexler, who some of you may or may not know, she actually wrote a book on this. Started out, she's a wonderful woman researcher, and as some of you might know, is now afflicted with the disease herself. She knew she was at risk. She started a project back in the 1980s to go to Venezuela, where there was a group of Huntington's patients, Huntington's people, um, near Lake Maracaibo in Venezuela. So this was the first project that was done to identify what the cause of Huntington's disease, and it really took a huge effort and multiple researchers. And within a few years, actually, they had mapped this disease to a chromosome or a gene. Um, so again, 100 years it took. So science takes a long time, though, but with concerted efforts, we do make discoveries. By 1992, we had discovered the Huntington disease protein. Originally, it was linked to a gene that we didn't really know the name of, but now we know the name of the gene, and it's named after the Huntington protein. So it's the Huntington disease gene, or HD gene. Okay, so I'm just giving you some highlights here. I'm not giving you the full timeline, but just to give a sense of how far we've come over time here. There have been mouse models and what are called preclinical models that have really helped us understand the disease process. How does this protein cause disease? And there's a lot of information that we've actually gained and has actually led to different treatments as well. The first trial was actually done in 2002, so it took another 10 years. So different trials. We don't use CoQ10 anymore. So CoQ10 is a over-the-counter supplement. It helps with the energy of cells, we thought, but a very large trial showed it really didn't help Huntington's patients. Therefore, we don't really recommend that. The real first drug to treat Huntington's disease was tetrabenazine, or Xanadine as a drug name. But tetrabenazine for chorea was first described and published in 2006. That was the first treatment for chorea ever discovered, as well as antipsychotics. Okay, so two different kinds of treatments. Now, of course, we've come a long ways. We have gene editing that I'm going to talk a little bit about. There have been a lot of different research trials. So in 2012, the Enroll-HD, which is a worldwide longitudinal registry following Huntington's patients over years and years, is a gateway study to different studies. This has also been piggybacked on. So we do different biomarkers. We look for things in the blood. We look for things in the spinal fluid. We follow patients on an annual basis. Some of you actually probably even participate in that study. But again, it's a gateway to other trials. And we've learned a lot over the years. Now there's nearly over 20,000 people worldwide who are participating in the Enroll-HD study. And it's actually going into a version 2, and we'll talk more about that near the end here. And what you can see on the bottom actually is some of the things that have led from all this research. So gene editing has led to gene therapies. We've had a few trials. Maybe some of you have heard about the Roche Genentech Generation HD trial that at least the first version failed. We do have a version 2 that's ongoing, and I'm going to talk more about that. There are other companies like Unicure and Voyager that have been doing some other types of gene therapy. I'm going to talk a little bit more about a new staging system for Huntington's disease. That's a research staging system that may actually change the way we look at Huntington's disease in a big way, at least researchers, and then clinically, as well as it may have some significant impacts on clinical trials going forth. Lastly, just recently, last year, we approved a third drug to treat chorea in Huntington's disease. So really, we've come a long ways. Again, took 100 years to kind of find the gene, but within a very short while, within just 30 years, we've actually have both new therapies for Huntington's disease to treat the symptoms, and we even have a number of trials and companies working on gene therapies to fix the gene. Like I say, it's the gene's stupid, so fix it. If we could, that's really the ultimate goal. And I'll talk more about some of the different strategies later on. So that said, epidemiologically, Huntington's is everywhere. Okay. Genetic diseases, we sometimes think about a founder effect. So, like one individual was the first one who had it, and then it spread and was inherited by others. But this has occurred worldwide. Okay. And you can see kind of by the map on the right, the hotspots are where a lot of Huntington patients are. Some of this may be just knowledge and discovery. So, there are some areas of the world where individuals probably don't get as much neurological care as they do here. And so we just don't know how many patients there are. But where there is medicine, where we know about it, there are hotspots. Worldwide, the prevalence is about 2 to 3 per 100,000, and it increases in different areas. So in Venezuela, Lake Maracaibo, the prevalence was extremely high, and that's why the researchers went there to examine this population of people, okay, and where the disease was first mapped and described. So, all right, so just some basics. So for some of you, like already know this. So Huntington's disease is a genetic disorder. It is inherited in an autosomal dominant fashion, and I'll have our genetics counselor talk a little bit more about that. But basically to say is that if you carry the gene, you're likely to pass it on. Everyone carries two copies of each gene, with the exception of the sex chromosome for men. But you have a 50-50 chance of passing that on to each one of your offsprings. Typical onset of symptoms occurs in the 3rd to 5th decade, but there's a huge range. So there can be what's called juvenile onset before the age of 21, okay? And people can even have onset of symptoms late into life. We have had several patients come to our clinic, even with being the first patient in their family having symptom onset after the age of 80. It's uncommon, but it does happen, and it can be a fairly big surprise for some folks. So, generally, there's the triad of features that we typically see, and that triad includes motor symptoms, cognitive symptoms, and psychiatric symptoms or behavioral symptoms as well. And the way this presents actually can vary, okay, quite a bit. So you may have all three, or you may have one or two of these, the triad initially. Eventually, pretty much all patients do develop all three of these symptoms, but in varying degrees, okay? This is a progressive disease. Typically, patients have a disease course of anywhere from 10 to 15, but maybe as long as 20 years or more, depending on symptoms and onset. Right. We will talk a little bit about the genetics more, and there'll be more information from Kayla later today about some of the expansions that occur. But suffice to say, the area of the gene that causes Huntington's disease is an unstable area of our DNA, and it can expand or contract, actually, sometimes causing earlier or later onset of disease. Okay. People aren't generally born with the disease. They generally manifest symptoms later in life, okay? Again, juvenile onset Huntington's, or we call JOHD, is rare, but can manifest differently in children, and I'll talk a little bit about that later in the talk, okay? So Again, motor features and presentations do vary. So this is just a good slide. I like to kind of show the overlap using a little bit of a Venn diagram of some of the motor, cognitive, neurobehavioral symptoms, because they do overlap a lot of times, okay? Some of the typical presentations are on the right. So in terms of motor symptoms, involuntary movements like chorea are very common. So chorea is this dance-like movement. We'll talk more about that. Poor coordination, dropping things, having balance problems, falling frequently. This can affect your coordination of speech as well as swallowing. Eye movements can be disturbed, slowed, changed. Um, there are other physical symptoms that occur in Huntington's disease, so they're really widespread. So non-motor symptoms like weight loss, sleep issues, sex problems, mood issues that range, as you can see on the right. And I'm going to talk about each of these in a little bit more detail for everyone. Okay. So terms of onset again, and I wanted to show you a little bit of a graph on the right here, but um, we think of this as a disease, but I'm going to start to kind of introduce to patients and families the idea of disease versus illness. So when we think about illness, that's what we're thinking about is when someone presents with or manifests symptoms of disease. And we're beginning to kind of think about these disorders as a disease in a sense. Now, you're born with the gene, you have the gene, and you just may present with symptoms later in life. There is a disease process that's actually probably ongoing, and that's what we're starting to learn early on here. We're learning more and more about this from our enroll studies and other studies in Huntington, is that there is a disease process going on. It may not be obvious to most people. Um, so disease or illness manifests sort of in that third to fifth decade, but there may be some subtle signs or features. Those subtle signs or features are what we call prodromal symptoms. So these are symptoms that occur early on that may not affect your daily activities, but may suggest maybe the beginning of illness. Okay. So they may be mild behavioral changes or subtle things that maybe family members might notice, or maybe you might notice that you're just not quite as sharp as you used to be, or there may be some mood issues that are going on. Of course, mood issues are non-specific. I mean, mood issues occur quite prevalently in our population, and that doesn't mean you have Huntington's disease or that's the beginning. So, these are symptoms that may not be specific to disease, but they may suggest the beginning of something happening. Okay, and you may still be able to have function. So we call all those things that happen early on, maybe subtle, like in coordination or clumsiness, things that you may see, but still you're able to work, you're still able to do everything at home. That all fits that prodromal stage. And on the right, I kind of show that. And then this sort of diagnosis here is where things start coming to a head. Okay, so manifest disease is when those motor features start to cause mild impairment. Okay, that's when patients show up typically in our clinic and saying something is wrong. Okay, so that's where the motor features come out, the involuntary movements, coordination, balance issues may, or either the mood or the cognitive issues are starting to have some impacts on life. More moderate disease is shown on the right here, where the people start to gain more disability and functional dependence. And then, as you can see, kind of what occurs here is the chorea eventually sort of, the motor part sort of levels off. And what takes over really is the impairments and the dementia late in disease. So that's a good news, that dementia is often later in disease. It can start to smolder in the beginning. We kind of call that mild cognitive impairment, but when it starts to affect daily activities, that's when we start calling early, moderate, or advanced dementia. Okay. So I hope this kind of graph on the right gives you an idea of sort of disease progression and some of the general stages that we talk about in the clinic. Okay. So I'm going to talk a little bit more about the motor features. So I already mentioned chorea. So chorea is what we call a hyperkinetic behavior. So it's excess activity, okay, or excess motor activity. Chorea is that kind of jerky, involuntary, almost dance-like. It kind of can flow from a limb that we see, that's commonly seen in Huntington's disease. And this is classic for what we call adult onset Huntington's disease. And we see other things as well, besides just chorea. Sometimes we see abnormal posturing. So a foot may turn out, or the arm or hand may kind of be deviated, or may, as you're walking, the arm may go behind the back, all involuntarily. Sometimes people actually have sort of chewing, or their jaw is really tight, or they have eye closure that's involuntary. And so those are what we call dystonias, abnormal involuntary movements that involve contraction of muscles. Coordination problems, I've kind of mentioned. The term that neurologists use is something called ataxia. So what that means is a discoordinated movement, and that can affect things both speech, swallow, as well as balance issues. Okay. Occasionally, the movements can be really fast or jerk-like, so they may be ballistic, but if they're really lightning fast, like muscle jerks, we call that myoclonus. And then lastly, occasionally patients have tic-like behaviors. So tic-like behaviors, so people may heard of the word tic or Tourette syndrome. So some of the symptoms are like that. This is not Tourette's. Okay, we know it's due to Huntington's, but tic-like behaviors are either vocal or motor behaviors that are repetitive. We call stereotypes. So they may be vocalizations, they may be swallowing noises, they may be blinking, or they may be head turning, or even repetitive hand movements that have some characteristic to it. The key feature here is usually tics are partially suppressible, and there's an urge behind them. Okay, so this is not that common, but it is seen in Huntington's disease as well. Okay, other features that are seen. So we talk about this as usually a disorder where you have too much movement. Occasionally, we also see features of we call less movement, okay, or we call hypokinesia, and that means Parkinson's-like features. So stiffness or rigidity or slowed movements, okay? It's really uncommon to see this as a major aspect of the disease. When we see that as a major aspect of the disease, actually a variant we call the Westphal variant. Uncommon, but sometimes we see that. And we actually see some of these slow movements or stiffness more often in we call juvenile or JOHD than adult onset patients. And medications can sometimes cause that too. Gait imbalance, we've talked about, are part of the motor issues, and we watch out for that. There are other features that we see in persistent motor movements. This is kind of why we have you stick out your tongue during your visit and try to hold it out for 10 seconds, grip movements. And the reason for that is really the involuntary movements that patients have. Slurred speech and swallow issues occur rather early on. It can be a major problem. And then impaired eye movements, and there are differences in reflexes. Okay. And again, I'll just mention this. Oops, oh, sorry about that. Going back. Gosh. I'll go kind of repeat this kind of comment that juvenile onset Huntington's disease is somewhat different, okay, in terms of presentation. There are similarities for sure, but in terms of frequency, patients can have a chorea presentation when they're really young. So they do have coordination problems. They do have all the features of Huntington's, but more often they can also have this slowness or this stiffness. We call that Parkinson's type features. Kids may also suffer from a form of epilepsy or recurrent seizures as well. And they may show up to pediatric neurologists first and be treated for seizures. And unfortunately, the progression is much more rapid in JOHD patients, and symptoms just progressive. Right. So let me take a step back, and I wanted to kind of focus today on some of the treatments for symptoms. So I'm going to focus for a little bit about how do we approach the treatment of some of these motor symptoms, because they can be really, limiting in terms of daily activities. They can cause coordination problems in terms of just being able to do daily activities, dropping things. Particularly if they affect gait and balance, they can lead to multiple falls. Now, treatment, I'll just kind of preface here, depends on the patient and the severity of symptoms. So if the symptoms are mild and don't really cause any problems, treatment is not always necessary. So What we look for is when treatments really cause impairment of daily activities and are causing safety issues. And that's when we start treatment, or if they are bothersome or socially embarrassing. Okay. So that's what we're looking for. So again, the hyperkinetic, the chorea tends to be the most prominent symptom that we're trying to treat. Okay. And there are two general classes of medications that we have in our disposal to actually use. And there are a few other ones that were tried in the past, and I'll talk about those as well. Some of those were things like amantine. That's an old Parkinson's drug. It's kind of a weak drug. We use it in Parkinson's disease to treat involuntary movements called dyskinesias, and it does help. But for chorea, this is kind of a weak drug. In the past, a drug similar to that called riluzole. This was something that actually came out and is still used currently for ALS or Lou Gehrig's disease. It's similar to amantadine, but is not quite effective in Huntington's disease. In fact, there are issues with it as well, and higher doses cause liver toxicity. So we don't really use that. Sometimes we do use, sorry for this going back and forth, sometimes we use what are called benzodiazepines. These are medications generally used for anxiety and can be sedating, but longer acting ones can be really helpful to calm patients down and reduce their movements. Now, of course, if you do have Parkinson's-like symptoms, treating with Parkinson medications might be more appropriate. Okay. But the two medications that or classes that we generally use for hyperactive movements these days are either antipsychotics or what are called VMAT2 inhibitors. Okay. So VMAT2 inhibitors and antipsychotics basically deplete dopamine in the brain. So to reduce movements, we want to reduce dopamine. And for patients like Parkinson's who have a lack of dopamine, we give dopamine increasing medications, just the opposite. So the two classes are antipsychotics, which have been around for many years. Now, we're not using them for psychosis usually. Of course, they can be. Antipsychotics basically are dopamine antagonists. So they basically block the effect of dopamine in your brain. Okay. And there are both typical ones and they're the second generation atypical ones that are better tolerated and preferred over the older ones, although the older ones may be stronger and sometimes more effective. They just have more side effects. So the newer drugs are what are called these VMAT2 inhibitors, and these basically deplete dopamine in the brain at the basically at the it's a vesicular depleter. Okay, so where the neurotransmitters are produced in the brain. And again, I mentioned that the first one that was approved was tetrabenazine years ago. And this was originally developed for treatment of schizophrenia, just like antipsychotics are for psychosis. The 50s, and actually, a lot of people were actually treated, and some patients were treated even for what are called hyperkinetic movements. So it wasn't until there was a study at Baylor in Huntington's patients, and later on this was approved as a phase 4 drug in several countries. So this was our first treatment approved specifically for Huntington's disease, chorea, in addition to antipsychotics. Okay. So we'll talk more about those. Again, I want to highlight that antipsychotics are really useful as well. The issue here and how we choose which one we use is that, antipsychotics are better for patients who have depressive or agitation. So depressive symptoms or agitation. Okay. So we tend to turn to these medications. They are more available. They're cheaper. These VMAT2 inhibitors tend to be more expensive. They're the newer version. The big risk for these medications is that if you do have irritability or depression, that's a big risk factor, and so can exacerbate those symptoms. So we have to be really careful starting these medications. So it's kind of flipping, and we have to this is a decisions made, kind of discussing with your neurologist which way to go. Sometimes we use both actually when needed. Okay. So I want to take a minute to talk about some of the additional choices. Tetrabenazine has been out. Again, the big risk factor for using the medication is exacerbating mood issues, particularly depression. A few years ago, a new version of tetrabenazine came out called Austedo. The generic name is do-tetrabenazine. So this is the same sort of drug, but it actually has what's called deuterated forms of hydrogen put on it. So it's more slowly metabolized, so a lower dose, as well as it has longer activity, and it tends to be a little bit better tolerated than regular tetrabenazine, which is now generic. This is still not generic, okay? So it's a little bit different, but has the same mechanism overall. I'll show you some of the data here in terms of studies. Here showing this is placebo on the top, and you can see that over the course of several weeks, the sort of the lines kind of deviate, and you can see that there was a huge difference between those who were receiving a placebo or sugar pill, for instance, versus deutetrabenazine improved in terms of their chorea levels. So a lower score was better improvement in their chorea, shown here on this graph. And the study was called the first HD study. It showed that it was safe and tolerable. There actually were very few adverse effects here. Some of the adverse effects are kind of listed here on the right, and you can compare them to placebo, but common things are fatigue, dry mouth, and again, way down here is depression, but actually a low level, and compared to placebo was actually comparable. So not a huge difference between the two. Although in our experience that patients do sometimes develop depression with these medications as well, so we do have to watch out for it. But generally better tolerated. So this is a new medication. It's now available both in twice a day, and then there's a once a day version of the medication to treat chorea. Now, the newest medication that just got approved, I mentioned this earlier, was Ingrezza, or valbenazine is the generic term for this drug. So this is a highly selective VMAT2 inhibitor that was approved originally for what's called tardive dyskinesia. These are folks who have either psychosis and they were treated with medications and developed what's called tardive dyskinesia. So this was recently approved as well for Huntington's disease after a phase 3 trial was completed here in the United States and Canada. So I had 46 sites, a lot of different participants, and I'll again kind of show you the same, sorry, this is same graph shown here. And what you can see again, you can see my thing is that the top is for placebo, and then this is valbenazine. Over the course of 12 weeks, a sustained benefit with the drug. And then if that's not enough, just in terms of measurement, this is from physicians. This is actually patient response. So this is the physicians, and this is patient response. And I think what you can see is that the proportion of patients who took the placebo and said, I'm doing better, okay? So very much improved is this blue on the bottom here, whereas I'm not improved at all, which is this orange color here up the top here. And you can see that percentage was significantly improved with patients who took the valbenazine. And this is a patient report saying, yes, I'm doing a lot better. So very few patients actually taking the medicine said they were actually worse, okay? There's about a quarter of patients said not much change, but the, 3/4 of patients said there was at least some minimal improvement to very much improved on this medication. So we're excited to actually have 3 different versions of the medications. There are differences in price, obviously, and it's something to discuss with patients. The key difference with this medication is it's not metabolized, it's more highly selective, and the thinking is really compared to tetrabenazine and deutetrabenazine, the potential for side effects is slightly lower, although there's never been a head-to-head trial. Likely to do that based on the pharmaceuticals, but there have been some studies that suggest that that is true. And so this is a once-a-day formulation and highly effective for treatment of chorea. Okay. So those are the new medications for motor symptoms and kind of what we thought. I do want to switch gears a little bit and talk some of the neuropsychiatric and the cognitive symptoms, since these can be even more disabling for some of our Huntington's patients. So I want to take a little time just to talk about these. So neurobehavioral symptoms are complex, okay, number one, and they can often precede the motor symptoms by years, okay, and they may be some of what they call those prodromal symptoms. So they can be really subtle, and they can last for years. And they certainly are challenging because they can overlap some of the other symptoms that we see and then vary in severity and frequency. So this requires a really careful medical history, discussion of current symptoms. We always have to ask patients about what are the medications you're taking and what are some of the factors that are kind of in your life that are affecting kind of your mood or your cognitive. So, if there's a stressful situation going on, that can certainly cause you to have some problems with attention and paying, dealing with things in your life. And so that can certainly cause mood issues, both anxiety as well as depressive symptoms. Right. So we always look through all those things. So um, the mood disorders in Huntington's disease are really broad, really, really broad. Okay. So they vary from being sort of apathetic and depressed to being hyperactive, manic, and even psychotic. So on the left here, I'm just talking about some of the depressive symptoms, and they can fluctuate, even bipolar. So the prevalence is pretty high. It depends on the estimates you see, but up to about 60% of patients. Most studies do, suggest that about half of patients do have symptoms of depression that could be mild to severe depressive symptoms, and it can be one of the earliest ones. And it's really not related to the mutation that we see. One key factor here I want to point out is the risk of suicide. So you don't always have to be depressed to be suicidal. So suicide can be an impulsive thing and can occur and is a big risk for Huntington's disease patients throughout their life. And it can be a higher risk in certain periods of time of stress, particularly. I'll give you a few examples, such as maybe testing and finding out that you just learned that you have the HD gene and that you're at risk, or you find out that a member of your family just passed away of Huntington's, and so those are stressful events. So, but I just want to point that out. The risk of suicide is 4 to 6 times higher than the general population, so it's a really big deal. We will ask about it in our clinic, and certainly if there are any thoughts or suicidal ideations, we do want to hear about them. And patients can contact us. You can contact the 988 line as well for help, and then your psychiatrist too. So there are other risk factors for suicide, such as benzodiazepine use. Those are things like Ativan or lorazepam or clonazepam. Those are medications that can suppress you and make you feel more depressed. Other medications that I want to point out are pain medications, particularly narcotic use. Opioids or narcotics are a very common cause of depressive symptoms. They are sedating, and overall chronic use can be associated with depression. So we're very sensitive to that. Again, I mentioned that some patients could have these ups and downs or bipolar-like symptoms and have mania. It's not that common, smaller portion of patients. So other symptoms in terms of mood orders include apathy. So again, a lot of patients present with this. So, over half patients have some sort of apathy or withdrawal, okay? And apathy withdrawal can sometimes be mistaken for someone being depressed. So apathy is really not wanting to do things or having a lack of motivation. And can easily be misconstrued as being depressed. And if you ask the patient, no, I'm not depressed, I just don't want to do anything. And it's really hard to get that person to get engaged or to do things with family members or loved ones. Anxiety, panic, of course, is another key feature of disease and can vary. Obsessive compulsive behaviors too. Washing hands, 50 times a day, turning red. It's just one example. Slamming doors, cabinets, other obsessive compulsive behaviors. Obsessions can be just repeated, being obsessed with a particular idea or something. And then lastly, I want to talk about psychosis. Okay. So this is a less common feature, but can occur in Huntington's disease patients. In adults, the most common way this presents is for what are called delusions. These are fixed false beliefs. Like, I'll give you an example of someone who believes that someone is cheating on them, for instance, and they just can't be convinced otherwise, or they feel like someone's out to poison them, or their medications are being tampered with. Or that there's noises coming from the wall, and they just believe that that's what's going on. And it's hard to convince them otherwise. So these thoughts don't have to be paranoid thoughts or persecutory thoughts, but they can be. Hallucinations, both auditory, visual, even tactile, that means sensory kind of hallucinations, or even smell are possible, but less common. Maybe a little bit more common in JOHD or juvenile Huntington's disease. There's also a feature of what's called euphoria, always kind of being high. Okay. But I want to bring up delusions because all of these symptoms are treatable, and I'm going to discuss some of those treatments as well. So Um, just talking about the psychotic symptoms, okay? There is a diagnosis or just a differential. There's a different reasons. Patients can have comorbid schizophrenia, so that's always a possibility. When these symptoms start, it's definitely something to bring up to your neurologist or your physician because a physician, if they're new onset symptoms, should sort of be exploring medications, drugs, or substance abuse, as well as potential infection or some metabolic issue that's going on. So getting some labs, okay, and evaluations, even a possible brain scan. Um, you know, it's surprising, patients with Huntington's disease fall, and if they hit their head, they may have a head bleed. And the only manifestation of that head bleed might be changes in mood or even psychosis sometimes. So SDH stands for a subdural hematoma. That's a hematoma in the brain. So getting a brain scan could be there. And other symptoms I mentioned, like being fixated on something. Okay. Risk factors for this are patients who have lower CAG, so not patients who have a really big expansion. And these are some of the other ones. Lower functional capacity and prior history of psychosis as well are risk factors for that. Okay. So let me switch and just talk a little bit about the neurobehavioral, the cognitive issues in Huntington's as well. And they kind of overlap, okay? But the major issue in Huntington's is a progressive dysexecutive syndrome. So what I mean by that, okay? So kind of what I mean about dysexecutive is executive function is being able to plan, multitask, put things together, make decisions, those kinds of things. But it's more than that, okay? And when I say dysexecutive, this is things that affect the frontal part of the brain, the reasoning part of your brain. So as you can imagine, if this is a part of the brain that sort of myelinates last as you grow up. So think about kids. They're a little wild, and as they grow up, they become more able to reason. Okay. So what we see manifest in many patients are changes in personality, mental inflexibility. This perseveration, what it means is like stuck on something. They can't change to a different subject, okay, and restlessness. Okay. Patients with frontal and dysexecutive syndrome sometimes become withdrawn, become indifferent, and I've listed some other features of that as well. One big feature sometimes that occurs is what's called disinhibition. So inability to know what's socially appropriate. So maybe outbursts, inappropriate laughter, crying, or just saying things that may not be quite appropriate in the right setting. Okay, impulsive behavior. So that's another feature. So, um, you know, how many of you have had family members who eat and gobble their food and end up choking? So maybe impulsive eating. Only impulsive behavior is really kind of getting up without asking for assistance when they know they have balance issues and they're at risk for falling. So impulsive behaviors are things they do without thinking about them and then may regret them a little bit later, are impulsive behaviors. Irritability and aggression, I want to mention, sometimes occurs later in disease. Irritability may be the early manifestation, but later can become more aggressive and even hostile or belligerent behavior. Okay. On one end of that spectrum might be antisocial behaviors that can lead to getting in trouble with the law. And that includes things like substance abuse, alcohol use disorders, and again, may lead to getting in trouble with the law and even lead to admissions to psychiatric care. Okay. Um, One other feature I want to kind of just highlight here is sometimes patients are not really aware of their illness or they lack insight to what's going on. And this can occur with a frontal dementia, okay, progressively. And this can be a particular problem, especially with someone who has a lot of balance or abnormal movements and balance problems, and they're falling a lot, but they're still doing reckless kind of behaviors. They're just not aware of what's going on with their disease, and they think they don't need to be treated because they don't realize that they have problems. Okay, um, lack of insight might actually apply to other behaviors, such as they clearly may have poor judgment. They're still driving, they're having accidents, and it may require sometimes a really difficult discussion about, maybe this person should be driving and they aren't aware of, and they're kind of a bit of it's not just denial, it's just not, it's poor awareness. The term we use for that is anosognosia in our clinic. But just to be aware that, some patients just aren't aware of things. And this might also apply to pain. We also see patients who really just aren't aware of their pain. They have almost no sensation of their pain. So they're just not aware of what's happening, and they may have injuries that they just don't know about. And you have to be really careful to look for that. So, but this can be a huge problem. And dealing with this it can be quite challenging. Sleep disorders are part of this as well. Okay. And waking up unawares and kind of confused too. So, talk about kind of the different things that we do in our clinic. We do have some testing that's available. We often will have you, when you come in our clinic, do what's called a symbol digit test. That's kind of matching symbols with digits. And then there's a kind of a trail test. And there's some other things that we look for in some of our exam. Apraxia is kind of problems with motor function. That's sort of for a learned behavior that we kind of evaluate. The thing I want you to focus on is just sort of the stages. There can be early, kind of intermediate and late stages of this. So in the beginning, some of these things may just be difficulty organizing and coping with things. But later on, this really affects work and daily life in the home. So, becoming unable to kind of cook or take care of the house and needing some more supervision. Eventually, later disease stages, all of these cognitive issues can cause sort of inability to completely manage any of your daily activities and requiring professional care. And then, of course, communication and other things can be affected too. So different stages for this. So I want to bring up sort of the impacts of this and how it affects Huntington's patients. This may be obvious for both patients and caregivers, but these mood and cognitive and psychiatric symptoms cause a lot of different issues for patients. The stigma of having Huntington's disease is not just the movement issues, but also the neuropsychiatric issues. Okay, having mood depression is definitely something that makes people feel kind of uncomfortable talking about. It may lead to low self-esteem or guilt. Some of these behaviors may lead to loneliness and isolation, which can make care very difficult, may lead to just distressive symptoms too as well. I mentioned sort of the lack of insight, but some patients have acute denial. It's not uncommon for both patients and family members to talk to us about their concerns about what's going to happen to me in my future. Okay, thinking about some of these symptoms, particularly with particularly with dementia, and sort of what kind of care, what am I going to expect later on? And of course, all of these things impact daily activities or ADLs, work, the ability to have leisure, and even social interactions. And on the right, there's something called social graces, and there's just this interaction with all of these symptoms. It just has multifactorial implications for life in general. So it's really important to have discussions about this, frank, with your physicians, and trying to help get some counseling and some treatment. Okay, so I'm going to talk about guidelines here. Again, for me, really always telling our students and our people who come through the clinic is that we need to treat underlying issues first. Okay, so if we can get rid of medications, offending drugs that are causing the problems, sometimes that's like magic and it works really great. Other things to think about before we start talking about adding drugs are things like environmental factors that can be contributing to the problem. So, someone has the dementia, Huntington's, may not be able to communicate their wishes. And they may not be able to communicate them in the right way, or articulate what they want. So they might be hot or cold, hungry or thirsty, and they can't tell you exactly what they need in an easy way. Lack of sleep, sometimes boredom, and even overstimulation of a patient can cause more problems. Okay, so think about kind of what's happening in the environment first. So behavioral strategies may include things like just redirection, change the subject, sometimes just leaving the room. Okay, putting them in a quiet place. All right. For cognitive issues, I'm going to kind of tell you right off the bat, right now we don't have a current medication, but there are studies coming and some potential medications. So I'm going to focus mainly on the neuropsychiatric issues. So again, there are both pharmacological and non-medication treatments. Psychotherapy should be used. Okay. CBT stands for cognitive behavioral therapy. The family therapy sometimes is important, and support groups. Okay. And then think about lifestyle modifications too. Um, Therapeutics, I'm going to discuss briefly. Okay. For depression, we use antidepressants, and there are many out there. Okay. Some can affect some of the HD medicines for chorea, like fluoxetine and paroxetine. So we have to watch about for that. Okay. Some medications also might exacerbate chorea. So we just need to think carefully about which medications to start. There definitely are anxiety medications. Antipsychotics help both with the mood, agitation, and the chorea. So sometimes one medicine kills several birds with one stone. Okay. And then we sometimes even use what are called mood stabilizers. Okay. Things like Depakote or divalproex and lamotrigine to help with symptoms too. So again, this is just a summary. Okay. About different treatments that are available for mood. We have several different kinds of antidepressants that are out there. Apathy is hard to treat. There's no one particular medicine. Some of these antidepressants are more activating than others, so we sometimes try them. But I often tell patients and family members you need to schedule events instead of asking them to do something, tell them to do something. And that might be a better strategy. Schedule events, okay? Like schedule regular exercise, okay, instead of giving them a choice. All right, and that may be really helpful. For anxiety modified stressors, there are treatments for obsessive compulsive, and there's new medication that's coming out potentially for irritability and aggression, this new vasopressin antagonist shown here. All right. Okay. So lastly, I'm just going to talk about challenges. Unfortunately, there's really nothing really great for apathy. There's no randomized trials yet, but there's something called remotivative therapies or motivating therapies. There are lots of needs. There's pretty good data on cognitive behavioral therapy, both for depression and anxiety. And there are interventions for irritability and other studies that are out there. I'm just showing you guys some more information. There are different therapies, this acceptance, commitment, compassionate, focused therapies. These are different things you can discuss with a psychotherapist as well. It really helps to have a provider who's knowledgeable and has familiarity with HD. I know, I hear from you all that that's hard to find. But seek out centers like ours and others, and we can probably guide you to find some of those providers. And some of those might actually be just here at UF and at the specialized centers as well. Okay. And we can help educate them. Lastly, I'm just going to say that, the bottom line is motor features that seems to define the disease, but it's really not all that Huntington's really is. So we have to treat the non-motor symptoms. There are a lot of different family implications and psychosocial aspects that we should address. And you got to look at some of the outcomes. So is it helping work? Is it helping, school driving, just daily activities and things? It takes a village. So, and we hope to be part of your village here and our multidisciplinary team here. So we have therapists, we have psychiatry, we have neuropsychiatry here to evaluate cognitive issues. We have a social worker, awesome person, and even we can help you with palliative care at our center. Okay, so I'm going to take a quick kind of switch over and break, but I want to kind of give you lastly an update on some of the research and trials. Is probably what you've all been waiting for. Kind of exciting what's going on in the HD field. Been at a number of conferences recently, and the explosion of research and folks that are working on these, I make you feel great that there's just thousands of people working on this. So I am fairly confident that we're going to have some solutions shortly. So with the advances that are going on, let me take a step back and just, for those who aren't familiar with clinical trials, okay, there are stages, okay, and phases. So what are those phases, okay? So a lot of it starts with preclinical research, okay? So first of all, just I would say like 90% of this is just working in the bench, okay? So getting to the patient, the bedside of the patient takes a long time. So a lot of stuff's going on in the preclinical labs, tests, sort of using cells or maybe even animal models to study this disease. And that leads to discoveries. And once we discover some sort of compound or therapy, it enters what's called a phase 1 trial. Phase 1 trials are really small. They usually involve less than a dozen patients. And they're really just about trying out a dose and seeing if it's safe and tolerable. Okay. So looking for that best dose. And if that works and safe, they'll move on to a phase 2 trial, which again is about safety and tolerability. But phase 2 trials are bigger, and often they're also looking for some signal or response. Okay. So does the drug target what they're looking for? Does it say, if the drug's going out the Huntington's protein, is it lowering the Huntington's protein? That's a target engagement. Okay. Um, they may be looking at sort of a hint at efficacy. So is it doing something? Is it making patients better? Making their symptoms a little bit better or slowing their disease? So that might be part of the phase 2, but it's usually a small number of individuals. The FDA or marketing approval requires larger trials. So usually trials that are successful in phase 2 go on what's called a phase 3, which may involve hundreds to even 1,000 patients. So it depends on the disease. Again, they're always looking for safety tolerability, but the big thing that a phase 3 trial is they're looking for efficacy. And once if this is successful, it gets submitted to a regulatory agency for approval, and that may lead to a new drug. Yay! So things like valbenazine did this. So then post-marketing approval, and there are phase 3 trials that are for drugs that are approved, and basically for phase 4 trials are for marketing and just to see how well the packaging and how its delivery to the patients and caregivers is. So let me talk about the bench to bedside. I think it probably won't surprise any of you that this takes a long time. Okay. Unfortunately, I say 2 to 5 years for basic science, but it's probably longer than that. Preclinical testing takes a few years, and then the clinical trials often take 5 to 7 years, and then regulatory approval takes a year or so. The fastest I've seen is maybe half a year to get to drug approval. So all in all, this can take 10 to 15 years. So it's bad news, but the good news is that people are involved, and there's a huge amount of individuals, regulatory agencies, people working all around the world to find those new treatments. I ask to be patient, but there is a process to make sure that these drugs work, that they are safe and tolerable, and the process does work. People are looking at ways to change the process to make it a little bit faster, like what are called platform trials and other things. But just understand that it takes a long time to get there. But it's all for you in terms of and safety to make sure. And their FDA is really strong. They're a little bit more tight in terms of their criteria than Europe. So often we see drugs approved in Europe before they come to the United States. But that's really because of the safety and just the rigor that goes into approving a new drug for you. Okay. So again, I'm just talking about the course of illness, which can last 10, 15 years or more for many patients. And there are different stages that have been proposed. I'm going to kind of focus on the right. These were proposed back in the 80s by Ira Schulson and Stan Fawn of different stages of disease. That stage 0 where patients have no symptoms or prodromal symptoms. Stage 1 where you're maybe a little bit of symptoms. Stage 2, stage 3, all the way down to 3 where you're really severely affected or bedbound. Okay. So that is the staging that has been proposed up to now, and it's really based on symptoms that we see in our clinic. So I'm going to talk to you briefly about this. I'm going to skip the genetics briefly, but just to know that there are different genetics for disease, and I'll let Kayla kind of go over that. What I want to talk to you briefly about is this new staging system that's coming out for Huntington's disease. So this was proposed by Dr. Tabrizi in 2022. There's a really good paper on this. And there's a couple of factors that are coming into this, is that this is based on all the different studies that you all have been participating in, providing blood and fluid samples and providing brain scans. So this comes back to that I have HD, I carry the gene, and the fact that we all know there's a disease process going on. And when we see people in clinic, that's when the illness is manifest. We would love to have treatments that stop the disease in its track before you develop symptoms of Huntington's, okay, before people have HD. So reversing disease is really difficult. Okay. I kind of liken diseases, Huntington's, like a forest fire, okay, in your brain. It's easier to stop a forest fire at the beginning when it started or prevent that forest fire. Once that forest fire in your brain is started, it's hard to stop it. And even if we do put that forest fire out, there's a lot of burn, there's a lot of damage, and we're not able to fix brain damage. Okay. So this is why I think this new stage is exciting. The new staging system is stage zero for Huntington's for people who have a gene. They're aware of their gene status. So I tag repeat that's positive over 40 or more. Um, so that's what we call stage zero. Stage one is actually identification of biomarkers, either imaging, at least that's the first thing here. So we have brain imaging that we can do. And we don't usually do that routinely in the clinic, okay? Because we don't see patients at this stage. We see patients when they have symptoms often. So if we could see them earlier, and we are going to start tracking patients earlier. Stage two is when there are prodromal symptoms. So we can detect them by cognitive tests. And the most sensitive one is the symbol digit test, okay? As well as mild motor scores. And then stage three is where it's usually when patients manifest, is when people have manifest symptoms of Huntington's disease, whether it's mild, moderate, or severe. So why is this important? Is because we want to identify people earlier in disease. And if we're going to have a gene therapy, we want to target people in these stages one, two, okay, ideally. And someday in the future, target people in stage zero when we can test for the gene. So, and do gene editing, but we're not quite there yet. Okay. So, there have been a lot of clinical trials. I'm going to just kind of go through these ones, and you can see on the right there's just no benefit or they failed. So a lot of these different drugs, I mentioned, CoQ10 earlier on. Ionis was one of that trial, the Generation HD trial that failed as well. And I'll talk about some of these, and there are a bunch of registries out there. Okay. So I'm going to kind of talk a little bit about this. Most of the disease modifying things are focused on the gene. So I said the gene stupid in the beginning. We want to target the gene and the gene product. If we can lower Huntington or mutant Huntington, we can probably fix the gene. And the thing is, the Huntington protein is abnormal when it's mutated, and it either has a loss of function or a gain of function. So loss of function means it doesn't work what it way it's supposed to be. Gain of function means it's actually causing adverse effects. So, and I think there's a mixed effect from that thing. So we do want to target the Huntington protein, and there are lots of ways to target it. We can target it at the DNA level, and you probably heard CRISPR-Cas. It's coming. Okay. It's just very inefficient right now. So a lot of research is going into making it more efficient. Right now, we can only do it on people where we can take the cells out, like, there's the best example right now is sickle cell disease that's been treated successfully so far. Okay. And maybe see more of that. But we want to try to treat the gene product, and there are multiple levels where we can treat it. We can treat not the DNA, but we can treat the RNA part with antisense. So ASOs are antisense oligos that we have to inject into the spine. So that was generation HD2 or HD and HD2 coming right now. And there are other ones that target the RNA and then the protein as it's developed. So there are multiple ways that we can target the protein. It's okay, the gene product and its protein at different levels. And so people are focusing on all these different targets. We need one winner, okay? That's all we really need right now. So let me talk to you about some of the trials briefly. I'm going to go over some. Some of you have heard about some of the gene therapy trials. Unicure is a phase 1/2 trial of AMT-130. So this is a trial where they're injecting a virus into the brain that lowers the gene product, and it requires 6 injections directly in the brain. It's targeted to patients who are earlier onset and have very mild symptoms, and the brain needs to be largely intact. So more moderate to advanced patients do not really qualify for this. So there's been some really positive studies, positive effects from this therapy so far in their first cohort and their second cohort as well. Um, it does show that they have been able to reduce the mutant Huntington levels by about half at 12, at month 12. There were a few patients with a higher dose so far that showed some inflammatory changes in the brain, and those patients were treated. So they're moving on to doing a new cohort. So people who are interested, who are early onset patients with few symptoms, have a lower sort of CAG repeat, might be appropriate for that study. Okay. Another study is one that's using the antisense. So Generation HD2 is the next version of Roche. So the first trial failed. Okay. One of the reasons also was that the higher dose seemed to be poorly tolerated. So this trial, the higher dose is now gone. So safety issues are not really so much an issue. They're focusing on really young, early onset patients. So people who actually are 25 to 50-year-old patients, and they have to have a score, particular severity score between here that we have to calculate. So only a few patients really qualify for this, but this is every 16 weeks, patients get an injection of an antisense oligo. So it's a study that's ongoing currently, and we are enrolling. Okay. Vibrant's a good example of a oral medication, so it doesn't need to be injected. This was a small molecule called branaplam by Novartis. It was a phase 2 trial that was ongoing. And unfortunately, there was a high incidence of people who had neuropathy. And so the trial was halted early on and stopped. Okay. So I'm going to talk to you about another oral medication shortly here. Okay. So we haven't given up on small molecules that can get into the brain and also do target the mutant Huntington protein as well. So I'm going to talk about some other medications first. Okay. Some of you participated in what's called the Prelinea pridopidine trial. So these are not necessarily disease modifying as a therapy, but the goal for the pridopidine was to target the sigma-1 receptor. It's a new target. It's also targeted for ALS. And the goal here was to slow the functional decline. And not to help the chorea, but to keep you functional. So this is, had persistent effects for 2 years. It looks really quite good, although it didn't quite meet its primary endpoint. It's still ongoing. The drug is available through an expanded access program. We can talk about that later in our Ask the Expert sessions later today. But this was extremely well tolerated, and it may slow progression a little bit. Okay, so it's an interesting drug. Again, oral drug once a day, very well tolerated. So other drugs I want to talk about. So far, there haven't been any drugs for cognitive impairment until Sage Therapeutics stepped on the stage. So Sage 718 is a trial, and they've had several recent trials. They did a phase 1/2, and they have another larger trial called Dimensions ongoing in this Purview, which is an open label study. So 3 trials. So I'm just, despite the details, but I want to tell you this is for cognitive impairments, one of the first studies for a drug that is looking to decrease cognitive function in Huntington's disease. So stay tuned. It's still an ongoing study. Okay. Some of the other ones to look forward to are Wave. So Wave Life Science actually did an antisense therapy just like Roche and Genentech, but this was targeted at the mutant Huntington protein. Their trials failed, but they have a version 3 that's coming out in the coming year. And version 3 seems to be more effective, at least in early trials. So it's going to be called Select 2, and we'll see how it goes. And we'll look for enrollment in that. But again, that's going to require injections into the spine. And because it's selective, so it's a selective blocker of the mutant Huntington protein, only a certain percent of patients are going to be eligible for this, and it'll require genetic testing to see if you carry the right markers to get into that study. BICO is another interesting study that's an ASO that's still kind of coming down the pipeline. Finally, there's a couple other studies. I'm a little excited. There's PTC Therapeutics that many of you might have heard about, and PTC 518. So this is another small molecule, just like Vibrant HD from Novartis, that affects Huntington, so lowering its effect on mutant Huntington in the brain. So this is a study. There's a phase 2 ongoing. It was halted by the FDA for a little while, but restarted. And we're looking for a new phase 2 or 3 study that's coming to the US soon. So the nice thing here is that there's so far shown a durable dose-dependent response in blood and spinal fluid of lowering the Huntington protein, and even some suggestion that it might keep levels of degeneration as measured by what's called neurofilament steady. So that's a good thing. Looking at another marker of brain degeneration. And there are more drugs on the line. This is a drug for hypertension, Bevantolol, that may be another novel VMAT2 inhibitor for chorea. So just stay tuned. There's a whole bunch of stuff going on. That's a lot of trials. Okay. Lastly, we talk only about medicines, but I want to mention activity. So don't forget exercise. There's actually data on this. Multi-center studies at 6 sites. So having moderate to vigorous exercise several days a week makes a difference. Okay. These patients were a Fitbit, and they seem to have a difference in terms of things, good adherence, good frequency, and something that we always recommend to patients. Okay. So I'm going to stop there. A lot of trials, a lot of information. This is our big team. Not all these people are Huntington's, but this is our big team at the UF Fixel Institute. Again, I want to thank you for your time.